Morning, everyone. I'm excited to welcome you to the New York Health Foundation's webinar on addressing disparities through school-based health centers. My name is Nikki Tadamonte. I'm a program officer in the primary care priority area here at the New York Health Foundation. As you might know, the New York Health Foundation is a private, independent, statewide foundation dedicated to improving the health of all New Yorkers, especially people of color and others who have been historically marginalized. As an independent foundation, we do not engage in lobbying, focusing instead on research, grant making, and partnerships to advance health equity and address systemic barriers to care. In 2023, the New York Health Foundation's primary care team sought projects to expand access and advance racial health equity into primary care. We sought to test replicable models to improve the accessibility, quality, and equity of primary care in regions across the state. From this, we awarded the New York School-Based Health Foundation a grant to participate in this initiative. Under this grant, the New York School-Based Health Foundation sought to identify racial health disparities among over 250,000 public school students across New York State. As someone without a background in school-based health services, this grant was my first exposure to the wonderful world of school-based health centers. If this is your first time learning about them as well, I'm sure you're going to be similarly impressed by how effective this system is at providing essential health services to all students at no cost to the families, at great benefit to communities in our state. But instead of hearing about school-based health services for me, I'd rather you hear it from the experts in the field themselves. I'm really excited today to welcome and hear from 3 dedicated and thoughtful experts in the field, Audrey Cruz, Lisa Perry, and Sarah Murphy. And we also have the Associate Director of the New York School-Based Health Foundation, Sarah Goldberg, behind the scenes running the PowerPoint, and our Communications Officer at the New York Health Foundation, Shannon McCall, guiding us as well today. So to introduce 3 of our panelists, Audrey Cruz is the Deputy Director of Health Programs and Integration at Children's Aid and the Treasurer of the New York School-Based Health Foundation. She oversees the Food and Nutrition Program, the Health Connections Program, and leads the integration of health and wellness services to reduce barriers to care for children and adolescents. Previously, Ms. Cruz managed the operations of 8 Children's Aid school-based health centers and led the launch of 2 new school-based health centers. She earned her undergraduate degree in accounting from the Universidad Autónoma de Santo Domingo, graduating at the top of her class, and a Master of Public Administration from Baruch College, where she was inducted into Pi Alpha Alpha Honor Society for Excellence in Public Administration. Lisa Perry is a healthcare consultant with extensive executive experience. Since 2022, she has served as the director of the New York School-Based Health Foundation, building the organization through fund and program development designed to strengthen and sustain the school-based health centers of New York State. Previously, as principal of Morningside Health Strategies, engagements focused on data-driven performance, improvement, and innovation, including fund development and project management for multiple programs of the New York School-Based Health Foundations. Prior to this, Ms. Perry served as the Community Healthcare Association of New York State, or CHCANYS, from 2008 to 2019, where she implemented the Centers for Primary Care Informatics, a statewide health management system, and the founding of a HRSA-funded health center controlled network. Sarah Murphy currently serves as the Executive Director for the New York School-Based Health Alliance and has held this position since 2014. Previously, she was Vice President of the Empire State Society of Association Executives, a statewide trade membership organization. Sarah Murphy has worked as an organizational consultant for several associations and societies. She is principal of a management consulting company, Seventh Sister LLC. So welcome all of you to our panel. We're going to start with a presentation from all of our panelists and then have 15 minutes at the end of the session for questions and answers. So for everyone who's joined us, I welcome you all to ask questions throughout the session and stay engaged. If a question seems pretty timely, I'll lightly interrupt some of our speakers to be able to ask it. But if not, I'll kind of collect them for the end of our presentation. And slides and recording will be available and emailed out after the presentation. And with that, I'd like to welcome Lisa Perry to begin our presentation.
Thank you so much, Nikki. Good morning, everyone. Very pleased to be here talking with you this morning. Next slide, please. Very briefly, this is our agenda. We'll introduce you to what is an SBHC, why they're so important, and then we will describe to you the project that Nikki referred to, investigating health disparities through our grant from the New York Health Foundation and others. Sarah will talk about the New York School-Based Health Centers policy landscape, and we will then entertain questions. Next slide. We're very grateful to the New York Health Foundation for funding this program. It wouldn't have been possible without their support. And we're very pleased to be able to share the findings with you today. Briefly, this is the mission of the New York School-Based Health Foundation: to provide technical assistance, research, and support for the growth, expansion, and advancement of New York State school-based health centers. We complement the member and advocacy focus of Sarah's organization, the New York School-Based Health Alliance. And now I'd like to hand it over to my colleague, Adria Cruz, for her introduction to school-based health centers.
Thank you, Lisa, and thank you, Nikki. Good morning, everyone. My name is Adria Cruz, and as Nikki mentioned, I'm a Deputy Director at Children's Aid, where we operate 6 school-based health centers across New York City, and I also currently serve as the Treasurer of the New York School-Based Health Foundation. And I have to say, in my 18 years working with school-based health centers in various capacities, I often turn to this cartoon when asked what school-based health centers are, because I think it beautifully illustrates why they're so essential. You can see here a boy carrying some heavy luggage, labeled hunger, sickness, and homelessness, and asking, could someone help me with this, please? I'm late for math class. And I think this image reflects a reality that many children face today, one that often goes unseen. Students don't just carry backpacks filled with books. They are often burdened by challenges such as hunger, illness, homelessness, mental health issues, and others. These struggles not only impact their health, but also their ability to learn, focus, and thrive in school. And this is where school-based health centers play a critical role, especially in our most under-resourced schools, by providing accessible healthcare, mental health support, and other essential services right where they are at school. So what are school-based health centers? School-based health centers are primary care health centers located right inside the school building, providing services to all students at no cost to their families, regardless of insurance or immigration status. These services are delivered by a dedicated team of professionals, which often includes, in terms of medical providers, usually it's a mid-level provider such as nurse practitioner or physician assistants, but also many school-based health centers are staffed by pediatricians, mental health counselors, and clerical staff. And at some sites, also we would have dental providers, health educators, and other specialists. So the services provided at school-based health centers include comprehensive medical care, such as physical exams, immunizations, and repro health services, pretty much everything that you would see at any pediatric center. Mental health services, which are offered on site or through referrals. And sometimes mental health services could be under Article 28 license or Article 31 license, which is kind of the highest level of outpatient mental health care, which is what we have at Children's Aid. Many school-based health centers also provide dental services and vision care, including the provision of glasses, either on site or by referral. And all of these services are coordinated with primary care providers and specialty providers as needed. So when we look at New York State actually operates one of the largest school-based health center networks in the country. Maybe we're number 2. We tend to go from number 2 to number 1, depending on how you describe a school-based health center, because other states may have a mobile unit outside of the school or could have a school-based health center that is shared between 2 schools. In New York State, they're all part of the school building. We currently have about 250 school-based health centers serving over 250,000 students across urban and rural elementary, middle, and high schools. The school-based health centers are located in public schools in low-resource areas where roughly 80% of students come from racial minority groups, and about 70% are enrolled in Medicaid. The source for this data is the New York State Department of Health, and a link is provided at the bottom of the slide. So when you get the slides, you'll be able to verify all this information. School-based health centers are sanctioned by New York State Department of Health and operated by federally qualified health center, hospitals, or community-based health organizations such as Children's Aid. New York City also have the Office of School Health, which provides a lot of technical assistance and some oversight as well. So in terms of impact, school-based health centers have been proven to improve outcomes for children that extend well beyond healthcare. The studies I'll reference here are linked at the bottom of the page again. So when you receive the slides, you can review them at your own pace. But evidence shows that school-based health centers can lead to improved school attendance for students engaged in school-based mental health services compared to their attendance prior to receiving care, reductions in school suspensions, as well as improved high school completion rates and higher grade point averages from the time when point A to point B, when they started receiving services to the end of either their treatment or as they continue to receive services within the school-based health center. From a healthcare perspective, school-based health centers have been shown to increase immunization rates, reduce emergency room visits and hospitalizations. And one particularly notable study conducted between 2008 and 2017 found that reproductive health services provided in New York City school-based health centers averted an estimated 5,300 pregnancies, over 2,000 births, and over 3,000 abortions, resulting in approximately $30.3 million in avoided one-time costs of publicly funded births and abortions. These averted events accounted for 26 to 28% of the decline in teenage pregnancies, births, and abortions in New York City during that period, which I think is pretty remarkable. Next slide, please. Thank you. In conclusion, school-based health centers are uniquely positioned to meet the growing health needs of children by providing care where they are, minimizing disruptions to both students' school days and parents' work days. School-based health centers also help reduce the stigma around seeking care by normalizing healthcare within the school environment. They have been shown to significantly address the needs of children in New York neighborhoods experiencing the greatest health disparities. To provide deeper insights into this work, I'd like to pass it back to Lisa Perry, who will share the outcomes of the Health Disparities Project funded by the New York Health Foundation. This project is helping us better understand how we can continue to reduce health disparities among the youth we serve. Thank you.
Thank you, Adria. So one of our largest programs at the foundation is our Data Hub program, which currently receives patient-level data monthly from roughly 60% of the SBHC sites across New York State. We have been aggregating this data for the last 4 years and publishing an annual report to help understand the impact, reach, and value of SBHCs. You can find the annual report on our website if you're curious after the presentation. In 2023, with support from the New York Health Foundation and other funders, we launched a special project to investigate health disparities among students seeking care in New York's SBHCs. Our objective in our Disparities Initiative is to explore the data and take action to remediate where possible. Before we dive in, we thought it'd be useful to share a few definitions. Health disparities, population-based differences in health outcomes. Versus health inequities, differences in health outcomes and the opportunities groups have to achieve optimal health that are rooted in avoidable, unjust, and unfair social and structural systems. And again, we want to credit the City Department of Health and Mental Hygiene for some really interesting publications, glossaries, and language use guides in this area. Next slide, please. So we're striving to go beyond equality to achieve equity, to eliminate or reduce those healthcare inequities. And the difference between equality and equity is an important one. When we prioritize equity over equality, we recognize intentional and unintentional advantages and disadvantages and make adjustments for a more balanced outcome. So the picture is always worth 1,000 words. And here, building on imagery from Shel Silverstein's immortal book, The Giving Tree, we can see that equality is not enough. The ladders are equal, but the environment is not, and the child on the right cannot reach the tree and the apples in the tree. Equity is what we strive for in the work of our SBHCs, with everyone having the resources needed for optimal health. In this case, it's a taller ladder. Next slide, please. The goal of our Disparities project was to increase access to information about health disparities among students who seek care at our SBHCs. We had several expected outcomes: to establish the prevalence of common and serious chronic and behavioral health conditions, to sort the data by race, ethnicity, and economic status, to assess any disparities in the distribution of these conditions, to identify disparities in health care using recognized standards of practice and measures of care quality, to discuss these findings at meetings of our Data Hub user group, to encourage our Data Hub users to develop planning around remediation where possible, and to disseminate our findings to interested stakeholders and partners like you. We worked with our Data Hub vendor, Apex Evaluation, to design analysis and reporting that would allow each of our participating organizations to examine its patient data for potential disparities. The project involved these 6 broad steps of determining the indicators that we would measure, as I mentioned previously, pulling the data, developing a custom report for each participating organization, and encouraging those organizations to get curious and look at the data to see what it might tell them. Steps 5 and 6 were addressed through a process we called the Disparities Action Planning, which I will discuss in the next slide. So the foundation created 2 templates for use by our Data Hub users: a Disparities Action Plan template and a Data Quality Action Plan template. A Disparity Action Plan is a set of steps an organization might take to explore and possibly remediate disparities identified in its report. The plan includes 1 or more goals with objectives and tasks designed to achieve the goals. While the roots of health inequity are deep and long-standing in our society, we strive to make a difference every day in our SBHCs by providing access to high-quality care for students in underserved communities. Through Disparities Action Planning, we have an opportunity to continuously improve, even with very simple actions, and we'll share a few of those on the next slide. The teams began to work on their plans at 2 workshops that we held in October and November, which provided protected breakout team time to review the reports and begin planning. And the sponsoring organizations, that's what SO is, are currently sharing their action plans with the foundation. So we are able to gather a cross-section of what people are thinking in response to their data. Several of these action plans will take modest steps to support students in achieving greater equity in healthcare. For example, several of the sponsoring organizations found that there was lower utilization of SBHC services by students in some racial and ethnic groups when you compare the percent of those groups in the entire school population. So they're working on developing a variety of remediations, including outreach and information gathering, to understand what barriers to access students may be perceiving that are keeping them from using the SBHC. This outreach includes to providers, parents, students, through focus groups, surveys, community meetings, a variety of responses. Some of our sponsoring organizations felt they could do some work to provide culturally responsive presentations on healthcare services at school-wide meetings or meetings of student organizations or parent organizations. And some decided that they would like to focus on remediating language barriers through improved interpretation or navigation services. Another example of a common theme was sponsoring organizations seeing lower completion rates of certain services, such as depression screening or physical exams for some of the racial and ethnic groups. Several of these proposed very simple changes in workflow and scheduling to promote greater distribution of these services across the entire student population. For instance, if a student comes in for any kind of medical visit, to make an effort to schedule a comprehensive physical exam, and also to make an effort to do a depression screening at every comprehensive physical exam. So these are, relatively modest changes in workflow, and we'll have to measure as we go along and hope that that will make a difference in the distribution of services. Finally, as is true for many organizations, SBHCs do not always have complete information on patient race. And work to address this type of gap is considered a data quality action plan. The work of these plans is extremely important to address suspected inaccuracies in data collection or aggregation. Accurate data is essential to identify disparities. So several organizations are considering changes to the forms used in gathering this data from patients and families. And one important change may be the inclusion of additional options, additional categories for race. One of our priorities per our mission is to increase public awareness of the value that SBHCs bring to communities throughout New York State. We strive to do this in our data work and dissemination of our analyses and reports through media, webinars, conferences. It is also vitally important that the public have an awareness of the political climate that has put SBHCs at risk. So I'm happy to present to you Sarah Murphy, the director of the School-Based Health Center Alliance, who will provide an update on what's been happening in the world of policy. Thanks. Sarah?
Thank you, Lisa. Thank you very much. Very glad to be here to have this opportunity to talk about what we're going through in New York State with school-based health centers. Briefly, school-based health centers share a very similar mission to the foundations. You see that we serve the same field. We have the same sort of points for sustainability, for promotion. We want to see expansion. What we do that you'll notice a little bit different is that we do so through advocacy and through lobbying. Next slide. So in New York State, sponsoring organizations such as hospitals, community health centers, and organizations like Children's Aid are the sponsors of school-based health centers, which are Article 28 satellite clinics. School-based health centers are a unique model. What they're able to do is complement traditional care and reach into and access hard-to-reach populations such as children in low-income backgrounds. To offer care that might be missed otherwise. We serve students that have disproportionately high health disparities. So the model complements what our sponsoring organizations already offer. And since our sponsors are also members of other organizations such as CHCANY's, the Community Healthcare Association of New York State, and also the Greater New York Hospital Association, Haney's, there's quite a few who also sort of serve the same population. So we benefit greatly from our partnerships with them in terms of our advocacy. What we don't do, and you can go to the next slide for this, is we don't generate a lot of revenue. Next slide, please. So school-based health centers themselves, in a good year, will break even in terms of revenue. We are fee for service currently and always have been since the inception of our program. But truthfully, it's the value that we bring in terms of the uniqueness of the model, the ability to reach into these programs to complement the care that is being given by our sponsors that make it worth having us. We're preventative, we're a community benefit, but we don't generate a lot of money. So it's important that school-based health centers, as a sort of a fragile economic model, at least sustain where they are right now. 10 years ago, the state announced that in their Managed Care for All initiative that school-based health centers were the next group on the docket to be carved into managed care. And we were greatly concerned at the time because school-based health centers have always been fee-for-service. The state had said that they thought that there would be better coordination of care and there would be better outcomes. We've never really seen anything, any citations saying that this is true. And we had some great concerns because in a fee-for-service model, the Department of Health serves as our intermediary. They're the Medicaid program. The school-based health centers are reimbursed at a regular rate. They have regular and continuous flow of revenue, and they have low denial rates. So when we heard that we were going to be carved in, we spent the last basically 10 years pushing back on that. We've introduced bills a number of times to maintain fee-for-service status permanently, and we have been successful until this year. In September of this year, the Department of Health and the OHIP, Office of Health Insurance Programs, made an announcement that school-based health centers would be carved into managed care as of April 1, 2025, which is a little scary. That's one school year. Within the confines of a single school year, we are supposed to move over a lot of infrastructure and a lot of pre-work in order to make a managed care program happen. So what happens if we are carved into managed care means that school-based health centers will now have to contract directly with plans. They will lose the sort of security and stability of having the state serve as the intermediary. And in order to sort of accommodate the special and unique needs of school-based health centers, not only would we have to kind of take a look at the infrastructure, the data systems and the billing systems of all of our sponsoring organizations, but all of the plans who also serve school-based health centers or currently don't serve school-based health centers would have to restructure their own billing systems, their own data systems in order to accommodate what is really just a small piece of a large healthcare system. So I can see where the plans really aren't interested in changing their systems in order to accommodate us. And they said so by not only issuing a memo in support of our bill this year, which we did have a bill this year, requesting keep us permanently carved out of managed care, but they directly refuted the Department of Health's inference that coordination would improve and that care would improve. So basically, we have a field of school-based health centers who have a very big fear of a destabilization. We're worried that we're going to see higher denial rates. We're worried that we're going to see lower reimbursement rates. We're worried that we're going to see delayed payments. Contracting credentialing is already a long, long process. And when you have a bill by date 90 days in, the two don't match up. And all of these parts and pieces are supposed to be in line with not only existing partnerships between sponsoring organizations and the healthcare plans, the managed care plans, but all of the new potential per sponsor clinic would have to deal with plans that they haven't had to deal with before. So we're talking about a whole lot of new relationships that would need to be built. And all this would have to happen in the next 100 days. So we're very concerned that we will see, as a result of all of that, sponsors who will have to take a look at increasing costs in order to make this happen, a reduction in rates, and then the possibility that they'll consider closing their programs as a result of that. They just won't see the value in the balance. And if we see school-based health centers closed, then we see care for these kids go away. And that's really one of our biggest problems that we're worried about. So ultimately, that's what our concern is we unfortunately just saw our last bill vetoed over this weekend. Next slide. So what are we going to do going into 2025? Well, historically, our bills have been vetoed, so that was not exactly a big surprise. We will go back and talk to our champions in the legislature. We will go back to our partnering programs, and we'll kind of move into 2025, into the budget season, to continue our campaigning to see if we can at least push off what seems to be a very implausible process happening in 90 days to maybe at least for another year. So that's really that's what our climate looks like. And that's why we are hoping that the governor sees our side of this discussion. And there it is. There's my little TED talk. So I hand the baton back to Lisa. Thanks so much.
Lisa, I think you're on mute.
Sorry. I think we're going back to Nikki now for questions.
Yeah, and thank you all so much. I mean, this is a wealth of information. Before I kind of go and ask you all questions as a group, I think there were two questions that came up in the chat for you, Sarah. One of them had to do with, like, in this world where we move to managed care in this carve-in world, would you be getting a per member per month compensation? Has there been details on how compensation would be structured? And then, in your opinion, are there limitations to kind of moving to that type of structure?
So Audrey, I don't know if you wanted to kind of speak to this specifically as an on-the-ground person. What we are looking at is that we would have to renegotiate rates per sponsor and per plan. And what I didn't mention, and I actually do want to kind of put this in there, is that we don't even know what would happen with our mobile units in oral health care. There are more than 100,000 visits last year just in New York City alone. What would this mean for dental programs if we moved into this sort of the managed care system where you would have to be the preferred provider? So we didn't even talk about that, but our oral healthcare partners are also very concerned about what this looks like, because we're not even talking about a per member. We're talking about potential for no revenue at all. But Audrey, let me turn that over to you for a sec.
Yeah, and partly also we understand, and by the way, this is one of the things that we still need to discuss with the state and the health plans, how everything will be implemented. And the deadline right now, it's April 1st, 2025 for implementation, which is a little bit scary when things have not been laid out. But in previous conversations, the state envisions that school-based health center services would be paid as if we were an urgent care center. So in managed care, you have a PCP that's already assigned, and it's usually outside of the school-based health center. So a per member per month is usually paid to a PCP, which oftentimes, while school-based health centers may function as the primary care provider, because many of our kids sometimes don't get to see providers outside of the school-based health center, but in essence, that the health plan assigns a PCP in their network. And I think the other piece to what Sarah was mentioning in terms of having to negotiate the rates, a hospital with a very large network of health centers would stand a better chance to negotiate a higher rate of payment than a smaller program such as Children's Aid, where we have 6 school-based health centers, and we operate as a community health center. So those are some of the concerns that we have. The state currently guarantees us a flat APG rate, and that wouldn't be available if we were to move into managed care.
Thank you, Audrey.
Lisa, anything that you would add there?
No, I do think the challenge of not being the PCP is a really large one in a managed care environment. It's hard to imagine adequate revenue under that scenario.
Yeah.
I do see, and I just wanted to address this, somebody had asked, and somewhere I see quite a few questions, whether or not the plan supported this, and if they didn't, where is this coming from? Well, the healthcare plans don't support this. They don't see value in having to restructure their systems, and they don't believe that this particular managed care for all coordination initiative fits with school-based health centers. They do believe school-based health centers are one of those entities, such as kids in foster care, and certain children with disabilities that really should sit outside of managed care, and we happen to agree with that. And our legislators also agree with us, and our supporting partners agree with us. So really, it's basically everybody on one side of this argument and the state on the other. And it's been that way for about 10 years now. So that's where we sit with that.
Sarah, have you seen any, resources or evidence from the state about outcomes or quality care improvement that might happen with this carve-in?
Well, I've heard it stated, but I've never seen anything cited is the problem is we've heard repeatedly better coordination, better outcomes. But truthfully, I think that the New York State Psychological Association actually asked this question years ago and brought in an expert, Dr. I want to say Henry Harbin, excuse me if I get that wrong, who had a significant role in Delaware, in Delaware's health system. I think he was a commissioner. And he also served as the CEO of a couple of very large insurance programs. And he had said there really isn't any. There's no proof that this results in better clinical outcomes. This is very much a state financial administrative decision. And it really, as far as I can tell, doesn't improve care. In our veto message, we were just vetoed this past weekend, and in the veto message, one of the statements had said that school-based health centers do not offer a full array of services and that managed care would help to solve that. And if you see programs needing to hire more people to handle the administrative burden of managed care, or potentially closing because of it, I just don't even see how that's possible. I think that there's been a lot of words, there's been rhetoric, but there really isn't a lot of proof in the pudding. And if school-based health centers are supported, as they have been told by the state, that they are a valued model, then we believe that the best way to support us is to allow us to remain in fee-for-service and to expand us from there.
Yeah, I mean, I think your presentation and spoke to kind of a lot of the outcome improvements, just kind of across the board and kind of system-wide improvements when you invest in kind of this model of care. And it seems like, from the Alliance's perspective and the Foundation's perspective and Children's Aid, there's, a lot of desire maybe to keep the system as it is, to not necessarily move to this managed care carve-in. There's some questions and comments in the chats about school-based health centers and whether they're patient-centered medical homes. Do they receive the additional PCMH payments? And whether there's any kind of advantage toward being patient-centered medical homes. That's something I'm not super familiar with, the relationship between PCMHs and school-based health center. Do any of you want to speak to that?
So to my knowledge, I think there is one PCMH program, and I think it's Bassett Healthcare, who do serve as the medical home right now, are recognized, certified as such. But as far as I know, I don't believe there's going to be any additional incentive that I've read about that school-based health centers will receive. We are waiting on a 10% increase in our fee-for-service rate that was supposed to be implemented in not this year's budget, but last year's. So we're still operating at a rate where we need to see better at a better reimbursement rate, and we would like to see school-based health centers who are PCMH receive incentives for that. I think that would be excellent, but I don't believe that there's a plan to do so, at least not right now.
Yeah. And there is another question in the chat from Sherry about, I think this is a question around kind of like the timeline and how these carve-in and carve-outs have historically worked. And so the question was, haven't these carve-outs been negotiated every year during the budget? And then, is there a concern this won't happen again, or is there room for kind of negotiation, do you think, within the budget?
Well, historically, that is exactly what we've done, is we've used every budget season to talk about this and to just say that the field is not ready. We have a policy document that is supposed to guide us through this, but originally 10 years ago, we had a number of meetings with all of the stakeholders. We were given the opportunity to ask questions. We had concerns about EOBs, and we had the opportunity to kind of work through that, or at least bring it up. This time around, we're not getting that. We had the announcement, which was made internally. We've had a single webinar. To my knowledge, I don't believe there's been any training or webinars for the plans to be involved in this transition. And so we are concerned about a lack of training and a lack of time. I mean, having this happen within a single school year is already hard. As as of today, I don't think I know of any plans or any, and I don't know the plans well. That's not, I'm on the other side. I don't know of any sponsors who are ready to go with all of their contracting, credentialing, sort of in place, or at least in process to make this happen by April. So right now, I think 0% of the field is ready to move forward with this, and we have no time left to do it. We have two major holidays and a whole budget season, and then we're supposed to be up and moving. So I think one of our biggest arguments at this point would be, as it always is where's the time to do this? Where's the guidance to do this? How are we going to do this if no one else sees benefit in it?
Yeah, 4 months is a pretty quick turnaround time from now. And
Yes.
especially as that's happening kind of in the middle of spring recess, in the middle of a school,
Exactly.
term. It's not like it's happening in summer or some other time. So it does seem like it could be pretty disruptive, especially if there isn't a ton of guidance from the state on how to do this or support to be able to do that.
And we're talking about plans and programs who have never worked with each other having to now work together in that same time frame. It just seems impossible to me.
Yeah. Well, thank you. And this is, I definitely want to, thank you for shedding light on some of this policy environment. New York Health Foundation, we're not involved in lobbying. We are an independent statewide foundation, so do not support any of this, but are very open to highlighting where our partners see opportunities. So, thank you for speaking to kind of some of the policy landscape. I think another question we had in the chat, which is maybe a little bit related to something that I thought of is this is especially for you, Audrey, because you've kind of stood up SBHCs and you've operationally managed a lot of SBHCs, but what are the challenges to establishing school-based health centers? And what are the biggest opportunities you have, or what are the biggest successes that you've had?
I would say the main challenge is that there isn't funding to open school-based health centers. I remember about 15, almost 20 years ago, the state had a pool of funding that they would kind of open up for folks who wanted to apply and open school-based health center. That grant has not been it's been renewed, but it hasn't been open for application in about 15 or more years. School-based health center expansion has taken place in New York City in the last, I would say, 10 years, thanks to some investment from from the mayor's office, at least in previous administrations. So there's been some expansion there when funds have been made available, but the main challenge is definitely funding. There's a need to do some construction. Dealing with the school construction authority, I can tell you it's not the easiest and it's not cheap. But there are ways to open a school-based health center, and there's a lot of interest. I mean, we get calls from principals all the time that they would like to have a school-based health center. The city does have certain requirements in terms of population, also the profile of the school, kind of the demographics, because we do want to make sure that the services go to the kids that need it the most. I would say those are the main challenges, just the financial kind of feasibility, because again, funding is not made available to open this on a regular basis. And then we have to rely on billing, which again, school-based health centers do not turn any patients away, whether they have insurance, active insurance or not, whether they're undocumented. Whatever the situation is, we provide services to everyone, and for services that go uncompensated, and then you don't have kind of that base grant funding, that's a disincentive to open new school-based health centers. These are not money-making machines. These are really programs to provide services to those who need it the most. And it usually requires a sponsor that's mission-driven to really support the school-based health centers. But I would say that the benefits and the satisfaction that comes from this work, it's priceless. And I think that's what keeps so many of us kind of pushing and supporting this field.
You know, and I'd like to add to that, that, you know, school-based health centers as a field have seen a reduction in their state-supported funding over the last 10 years, and we really haven't caught back up to that level. And, you know, we're post-pandemic, we served a role in pandemic care. And at least in the city, we've got some support from the city Department of Health and the mayor, but upstate, they're kind of left to their own devices to find their operating funds. You'll notice that there's some comments about the rural communities. And I mean, that's its own whole set of issues that need to be addressed. We see opportunities for expansion to meet the needs of our rural partners and our urban partners. And we would like to talk about how to expand the model and how to support it with additional state funding before we start to talk about how they're being reimbursed. We think we would like to see that as, if it's going to be a conversation, it would be further down the line. We would like to see the model really rise to the occasion and to optimize the kind of care that it could offer right now. I think that to us is really more of the primary goal.
I want to address some comments I see from Cindy, and thank you, Cindy. I appreciate all your comments. You know, one of the challenges about kind of being a PCP and being compensated by MCOs, if the school-based health centers are paid as, or the services are paid as an urgent care center type service and not as the PCP, usually those kind of outcomes-based payments are not available for those providers. School-based health centers, because we're based in the school, we're closed in some of those holidays, the school holidays. I think many school-based health centers remain open during the summer, but I don't think it's a requirement for all. So in order to be a PCP, you need to be able to be available, you know, on a regular basis every single day, even, you know, when school is out. And I don't think that happens across the board in New York State. So that's the main challenge in terms of becoming a PCP. I think someone else was asking that question as well.
Yeah, thank you. And you know, one of the questions I wanted to ask is in the opening slide, when you showed that comic of the student carrying the bags of like hunger, sickness, and homelessness, and the caption of like, could someone help me? I'm late for math class. It kind of speaks to a lot of the not only health problems that students face, but also some of the other health-related social needs. Could you tell us about how school-based health centers are kind of like engaging students in solving some of the health-related social needs, or are there limitations there? I know Emily in the chat just asked a question about connections between food offered in school cafeterias. So I'm just wondering if you could speak to any of those relationships or limitations that you see in school-based health centers addressing some of those social determinants.
I would be happy to address some of that. I mean, Children's Aid is a unique program because we also have community schools. In fact, all of our school-based centers are part of a community school. Children's Aid run 22 community schools where we provide after school and then a lot of other supports outside of the school-based health center. But even for those sites that only have school-based health centers across New York State, you know, I know many programs have a health ambassador program. We have such a group in a couple of our high schools where we actually engage the kids to become health ambassadors. It becomes a club where every week they're meeting either with the mental health provider or the health educator, and they come up with their own projects. And we have seen some of our kids actually take on the school cafeteria and the food that's being offered in the vending machines, etc. It's usually work that doesn't get an outcome within a school year, but we've seen kids actually fight for changes across several years and actually turning things around in terms of the food offered in the cafeteria. And certainly through mental health services, you know, one of the things that our mental health providers support is definitely that kind of case management as needed, and helping make sure that we are connecting kids to services that they need. Every single school-based health center will connect uninsured patients to insurance. We do several screeners, including around food insecurity. Some of these practices are kind of based on what each program provides, but these are models that we have across the state. And usually when there's a screener, there's a referral, and there's follow-up. I mean, the beauty of the school-based health center is that you can just come back the next day. And there's that follow-up. If we need to see a child, if we need to follow up and see they were able to get the services that they need, we'll be able to get them. There's no need to make an appointment. You know, in terms of addressing social determinants of health, like now our 1115 waiver is going to be paying for transportation expenses, for nutrition. Certainly school-based health centers are going to be part of this model. You know, those sponsors that consider it will, and Children's Aid will definitely be doing screenings to make sure that we're connecting kids to those additional services. But, you know, the main barrier that's removed is that transportation barrier. Kids do not need to take time off from school and go to a clinic, you know, even if it's just 30 minutes away in a train. The parents don't need to take a time off from work. So services where kids are remove so many barriers, including that piece about reducing stigma, because it's normalized that you seek help and you fight for your health, and it gives you agency too.
I don't think anybody could explain that better, Adria. Yes, the sponsoring organizations who have school-based health center programs tend to already have quite a network of existing community related organizations who would serve the needs of the community, from families. And as Adria had said, there's quite a bit of social determinants of health screening that happens sometimes even informally. During the pandemic, where there were food pickup locations, school-based health centers co-located themselves, and as food was literally being handed to kids or to families, school-based health staff would pull a child aside and say, is there violence in the home? Is everybody eating? Do you have heat right now? So these things sort of naturally come into the process of bringing a child into to a school-based health center. The Alliance is a member of the New York State Community Schools Network. We believe that a community school has a gold standard if there's a school-based health center in it. So we also work directly with our partners there and with our school partners, because as Audrey had said, there are principals calling our sponsoring organizations and our members every single day looking for this kind of care. So yes, we do assist with linking to other community service providers for sure.
Yeah, thank you both for those wonderful answers. It's very, very clear that there's a lot of thought behind kind of addressing social determinants and integrating some of the social work pieces and care coordination pieces. Lisa, I wanted to spend the last few minutes kind of discussing kind of the project that we kind of funded, and was particularly interested in some of the themes you identified, including finding there was lower utilization and lower completion rates of different types of screenings, like depression based on race or ethnicity. And I know that you're kind of, taking these general themes across all the school-based health centers and then working with school-based health centers individually. Can you characterize how these health centers have reacted to learning about some of these health inequities and what strategies that they've been taking on to kind of address them? Oh, I think you're on mute.
Sorry about that. There's been a real, I would say, openness to looking at the data, wondering about the data. These are things that many times the SBHC had not had this kind of data, so could not have known, for instance, that I'm thinking of one sponsoring organization where the use of the SBHCs was very heavily skewed to the Hispanic population. In terms of the Hispanic population's representation in the entire student body, there was a higher percent utilization by Hispanics of the health center than of their representation in the student body, and conversely, a lower representation of Black African American students than in the entire student body. And really, that could not have been known without being able to measure a 5 or 10% point difference. And it would have been hard to know just on your impressions of who's coming in day to day. So there was surprise and sort of wonderment and okay, let's buckle down and see what we can do about this. So just a very positive attitude, a gratitude for the data, because some of these things are very hard to know without data, and the data tells you that something's going on, but it doesn't tell you why. And so the disparities action plans are really the why part. Is there some fear? Is there some belief that's prevalent in the community? Have parents told their children not to use the SBHC? Really, it's now it comes down to trying to understand what is happening in the thinking of folks in a particular group that might be causing lower utilization. And really, is there something that can be done about it, or is that student choice? Or will provision of more information or more education cause people to change their minds? We don't know, but there's certainly a willingness to try.
Yeah, no, it strikes me what you're saying of, you can work day in and day out and not necessarily notice the patterns because you don't necessarily think about, okay, this is the population of this school and who am I seeing day to day? And unless you have the data to kind of uncover that, you might not know that there are disparities that, you want to solve. And I think it's important the role that data plays here in addressing some of those disparities. So, I want to end on a question of, if you had a magic wand, what would you use that magic wand for to change the SBHC field, to either improve health or to kind of reduce health disparities?
Magic wand.
It's powerful.
I mean, I think it all comes down to sustainability. We have a field filled with passionate providers. Every single person that comes to learn and understand school-based health centers loves it, and fights for it and defends it and supports it. So what we need is to have those that sustainability piece, the long-term sustainability, so that we can focus on quality of care and not on survival every single year fighting for that extension. So I would say that's my wish for 2025.
Well said.
Yeah, financial support, maximizing our model and expanding who we can reach. That's what we want to do. It's the whole point of the Alliance.
Lisa?
Yeah, I would say money is really the fundamental building block. The interest, the spirit, the willingness is there. So many of these sites are so thinly staffed. We often are in meetings with senior medical folks, and they're pulled in many different directions. It's a very it's a very rewarding and challenging work environment. And in order to really be able to invest in improvement, whether it's quality improvement or a disparities initiative, they need more capacity. It's amazing what is done with the staffing that is available. And so I think, sadly, funding is really the key component right now.
Well, thank you all so much for joining us and everyone who decided to tune in. I think we're all very impressed by you three experts, and just thank you so much for all of your effort in improving kind of health of New Yorkers. And we know that these investments in the health of children really live on and reap system-wide benefits beyond just changing individual lives. So just thank you so much for taking your time today. Slides and recordings will be available online. Lisa, Sarah Murphy, Sarah Goldberg, Audrey, thank you so much again. And I hope everyone has a wonderful day.
Thank you, Nikki.
Bye.
Bye.
Bye-bye, everybody.